Good morning. We have a technical issue. Carolyn is not appearing here. I'm going to pause. I'm Dr. Rosensweet, and Carolyn's camera. Well, let's see here. Carolyn and I are communicating as we have a technical glitch. It's like waking up in the morning and it's time to go to the dentist, and you want to be on time, and you go out and you start your car and it doesn't start. Has that ever happened? Carolyn's going to reboot here. I'm sure you'll be fascinated by a technical issue. One thing you all could do is, good morning, Facebook user, is if you have any questions, post them in the chat. I'll start answering those questions as we have a chance to solve what is an IT issue. So please do that. So if you have any questions, like Facebook user, post them right in that chat. Okay. Does Utrogestin help with PMDD? Utrogestin, never heard of it, and I'm going to look it up to see what that is. And PMDD, oh, I should know that, of course, and I'm not sure. Premenstrual dysfunction disorder, I'm going to open up and I'm going to see what that is. What both of those are. It's bioidentical progesterone. Let me see what that is. Yeah, premenstrual dysphoric disorder. It can. If and I want to look up Utrogestin. Yeah, it looks like it's Yeah, we're having quite the dynamic show today. Let me ask if anyone else can, Facebook user, can you see Carolyn's image? Yeah, it's micronized progesterone. And now, finally, to answer, premenstrual, um, um, yes, I'm going to type this to Carolyn, who we are in communication here. Thank you, folks. This would be the most technically challenged show of today. Let's see. The question was, can a micronized progesterone help with premenstrual dysphoric disorder? And what is it? That's a fancy name for the PMS, uterine cramps, heavy bleeding, these kind of symptoms that are exaggerated natural functions that can occur in the perimenopause. And they can occur any time, actually. What's usually missing there? Well, for you, Facebook user, if it turned out that one time in your life that your periods were normal and you didn't have severe uterine cramps, you didn't have premenstrual dysphoric disorder, where lots of things went off, like your emotions and your physical symptoms. If there was a time in your life that you did not have those, that you were a young menstruating, regularly menstruating woman, and you did not have these severe symptoms, and now you do, the most likely biologic issue going on is you lost your progesterone, and you're producing very minimal amount of progesterone. And in order to produce the robust amount of progesterone that is what women do when they're regularly menstruating, you have to ovulate. And those who ovulate have these super regular periods, clockwork. So the flip side of that is, if you are having super regular periods, you're ovulating, most likely. And if you ovulate, then the cells that surrounded the egg that got ovulated, got passed out of the ovary down into the uterus, the cells that surrounded that particular egg, they become progesterone production factories, and they put out these really robust amounts of progesterone. Progesterone, a woman's body loves progesterone. And progesterone is a real balancer to estrogen. So estrogen stimulates the uterus, for example, stimulates the uterus to produce an endometrial lining that can receive a fertilized egg, stimulates breast glandular tissue. Progesterone balances or calms that stimulation and prevents overstimulation. And if you don't have progesterone, you get overstimulation of the uterus and you get heavy uterine cramps. And progesterone is the great calmer in general. It has central nervous system effects. So if you don't have progesterone, you get mighty emotional in a very uncomfortable way, sometimes severe, simply from not having your normal progesterone. So the answer is, if you've got premenstrual disorder, and you didn't used to have it, and now you have it, you ceased ovulating. Or if you're ovulating irregularly, some periods, some cycles, you feel fine. You don't have premenstrual disorder. That happened to be a cycle that you did happen to ovulate. But if you get another cycle that you didn't ovulate, you didn't produce that progesterone, you don't have that progesterone to balance that estrogen and the tremendous stimulatory effects that estrogen is, you get uterine cramps, mood challenges galore. So does micronized progesterone taken orally help with that? You betcha. Now, it's not my favorite way to begin a woman. We love to see if a woman gets those symptoms alleviated by topical progesterone, but we'll very quickly switch to oral if she's not getting the relief. And we'll start low. This Facebook user says that she takes 50 milligrams progesterone every night and still can't stay asleep at night. Well, I need to know more about you. If you're Diane, one Facebook user commented that most mental symptoms cyclically happen in the luteal phase, which is the the third and fourth week. Yeah, when your progesterone, that's when if progesterone is going to come on with ovulation, it's going to come on mid-cycle when you ovulate, day 12, usually in a 28-day cycle. So that's when you can really get the severe symptoms like luteal phase depression and anxiety and mood swings. Yeah, without your progesterone, the great calming thing, you can get plenty of mood swings. So 50 milligrams, I'm going to talk about that. If progesterone is the only issue related to sleep disturbance, and it sure can be, I mean, if we inject the proper amount of progesterone into anybody, male or female, it's so calming that if we get the right dose intravenously, we can be put to sleep so deep surgery can be put on it. It can be performed on us. Not that that's used as an anesthesia, but that's how profound progesterone is. Ah, here comes Carolyn.
Am I here?
You're here. And I'm in the midst of answering a question, so you'll pick up in just a bit. So, welcome.
Thank you.
If you take, if progesterone is the main reason that you're having trouble sleep, and you're taking 50 milligrams, you may need more progesterone. And what we do in the method that we do when we switch to oral progesterone, we give a woman 2 bottles. We give her 30 capsules of 25 milligrams and 30 capsules of 75 milligrams. And we want her to find her optimal dose. So we start out usually with 50 milligrams. 50 milligrams is a good dose. And we do that for 3 nights. And if that doesn't improve your sleep and your and the premenstrual disorder, then we'll go up to 75 milligrams and if that won't keep you asleep, then we'll go up to 100 milligrams. I mean, there are physicians who are prescribing up to 300 milligrams of progesterone orally and are real world experts. That's a lot in most cases, but even the commercial, and I bet you the commercial Prometrium, which is the common commercial production, they only offer it in 100 milligrams and 200 milligrams, just to give you a context. They're not going to be producing hundreds of different dosages. They've chosen 2 dosages. What did they choose? 100 milligrams and 200 milligrams. So 50 milligrams can be a really good dose for some women, but it may not be enough. So we like to titrate up the dose. We like to start low and gradually increase and go all the way until a woman gets symptoms of progesterone overdose, which can be too calming. So if you take 150 milligrams of progesterone at night and you wake up in the morning groggy as if you got overdosed with a sleeping pill, that's too much. We would back you down to 125 milligrams. So with something as strong as premenstrual disorder, we would want you to titrate right on up to maximum progesterone and see if that alleviates it. Now, in the perimenopause, and these are the things that I do not know about this questionnaire, is how old are you? What is your history of your periods? These are the kind of things that a good healthcare provider will ferret out in their initial questionnaire. They'll learn a lot about you. I don't know very much about you, but if you're in the perimenopause and you're having sleep issues, there can have 2 different hormonal elements to it. One can be the low progesterone, the other can be the low estrogen. So there's a lot of moving parts. It takes us down to your basic challenge. For every woman, it's always the same thing. I would not advise trying to go to medical school to sort out your menopause. I would not recommend that you become a world expert on menopause. I recommend that you have one big job to do. And that big job is to find a healthcare provider that really understands menopause, really understands hormones, really is into it. And then it's just like me and my auto mechanic. I had to find a really great auto mechanic. And once I did, they figure it out. I bring them the car, they figure it out. The ideal situation for all women is you find someone you really like and trust who's been specially trained in treating women in menopause with compounded bioidentical hormones, really knows what they're doing, and let them take the wheel. Now, having said that, I know that this is very, very primitively historical times, very primitive. 2023, my God, we're still in the dark ages in many ways. And so we have to respond to the lack of knowledge that's out there. So one of the things I did in the early 2000s was write a book called Happy Healthy Hormones that Carolyn offers on the Facebook Live, a PDF version, no charge, because it is handy for women, especially if they can't find that excellent provider. It's handy for women to really understand what's going on and participate in their program, which was my original thought. These hormones weren't going into my body. They were going into the individual woman's body. I knew women differed, just like men differ individually. We look the same. All men look the same. I can take comments on that. All women look the same. Well, biologically, we behave very similarly. There's a lot of similarity to us. However, there's individuality that is really remarkable. So every woman, we feel the best way for a woman to be treated in menopause, or a man in andropause, is to start with low dosages of the 4 hormones and gradually increase them to alleviate symptoms of insufficiency. And if you go too high, you're going to go into overdose. You're going to get symptoms of overdose. So you back down. So we describe this in great detail in the book. And so when I talk about titrating, starting with 50 milligrams, going up to 75, going up to 100, I describe this in great detail in the book, Happy Healthy Hormones. Carolyn's made it available. She always puts it in a prominent space in the Facebook page. So learn how to titrate. And also learn that progesterone is not the total answer. You get in the perimenopause, you can start getting low estrogen. You're going to need some estrogen as well. So long answer to PMDD.
No mistakes.
Yeah.
Good thing that question came up. Very quickly, I will say a question comes up: where do you find these so-called experts? So you can always write to me, and I can go ahead and give you Sherry's address so that we can try and hook you up with a really good menopause method. Doctor trained by Dr. Rosensweet himself. Right?
Yep.
Cool. All right. So guess what? I have questions too. And they're right here. And I'm going to ask them. And I'm hoping that you will answer them for me. And thank you. And welcome, everybody. And thank you for your patience. First question comes in. I'm curious as to why Dr. Rosensweet does not like thermograms to rule out breast cancer.
Well, I had my concerns about mammograms when I started out as a young doctor. And then when thermograms came along, I was an early. I saw that early on. I saw it in the late 90s. And I found an expert thermographer in 2000. There weren't very many at that time. And I was very excited about them. But I wasn't about to stop doing periodic mammograms. So what I would do is I would write a prescription for once a year or once every 2 years, whatever the proper thing was for the individual woman based on her risks. I'd give her 2 requisitions, one for mammography and one for thermography. And I did that. And then in the early 2000s, I had a shocking experience. One of my menopause patients had a 34-year-old daughter who was a holistic vet, and she wanted me to see her because her daughter had breast cancer. And I met with the daughter, and here was the story I was told, that that she had felt a lump in her breast. This is the daughter, 34 years old, 2 kids, 4 and 2. And she went and got a thermogram because she was a holistic vet. And the thermogram said that this was not cancer. And she didn't do anything about it. And the lump began to grow and grow and grow and grow. By the time she sought expert surgical consultation, everything was too late. It was too late to treat her in any way. The lump had grown and metastasized, and they could not offer her treatment. She passed away within 6 months, leaving behind a 4-year-old and a 2-year-old and a bereaved husband and mother. When you're actually a physician and you actually have these experiences, they are extremely impactful. They can guide and steer a whole approach to medicine. My enthusiasm for thermograms evaporated on that day. And there was other experiences too. I had 2 different patients that I had given the prescription for a thermogram and a mammogram. And on their annual revisit, what I saw is they had done the thermogram, but they had not done the mammogram, for reasons that women have about being concerned about the radiation and the pressure. And I said, well, at this stage of my career, we also want to see the mammogram. And I had already been sensitized by that experience of that young holistic vet who passed away. And I said, well, you got to get the mammogram if I'm going to continue with you. And both of them did. And both of these women had a breast cancer detected on mammogram that was not seen on thermogram. It was caught at a very early stage. You catch breast cancer at a very early stage, it's almost 100% curable. Yeah, you got to go through a process that no one would love to go through, but it's a miracle for the women who catch it early and they go through that process. And it's lumpectomy. It's a simple lumpectomy, and sometimes chemo, sometimes radiation, sometimes local chemo. And no one loves to go through those things, but they're curative. It's not a question. You catch something early. Now, one of the women was really angry at me that I haven't emphasized to her the importance of getting the mammogram at the same time. I thought, yeah, come on now. I did tell you, I did give you a requisition, but that's another story.
Well,
So no matter what people might tell you about thermography, my experience is it can miss breast cancers. And so that's unacceptable to me. And yes, mammography can miss breast cancers too, but it's pretty rare. And so having said all that, I will get thermograms still to this very day because they are useful for something. Like if there's a breast lump there, or there's dense breasts seen on mammogram, or a woman knows that she has dense breast, she may even know that she has fibrocystic disease, which is really increased breast density from overstimulation of the breast glandular tissue. Nothing mysterious about it. Thermogram will reveal whether there's increased heat within the breasts, whether they're dense breasts or whether there's a localized lesion that's not cancer. If there's increased heat, that's a sign of inflammation. And we want to do what's necessary to eliminate that inflammation. And that's not hard to do. And in the book, Happy Healthy Hormones, again, you can download a free copy of a PDF version of it. There's things that we do to address breast density, increase breast density, to reduce the inflammation. And we even have a segment in our professional training program, which is 12 hours long. This is designed for healthcare providers, where we show serial thermograms of a woman who had increased breast density. She did not have breast cancer, but she had increased breast density. That's a risk factor. That's not a healthy breast. So we did what we needed to do, and we show serial thermograms where the heat disappears. How do we do that? Basically with iodine supplementation and no bra wearing, or reduced brassiere wearing, and eliminating compression bras, and doing breast massage. Breast health has some positive activities to do, especially for those who are having challenges there. And we list those in the book, Happy Healthy Hormones. So it's not that I don't like thermograms. Periodically, whenever we see increased breast density, or whenever we see that a woman needed to titrate up to robust levels of estrogen to have healthy bones and healthy vagina, a little bit higher than what we're used to, that automatically triggers a thermogram. It's okay to be on more robust levels. Some women need it for their cognition and for other reasons, for their mood. That's okay. We accept that, but we get more intense around evaluating that the breasts are not getting overstimulated. How do we know that they're overstimulated? We're going to see a change on mammography, or we're going to see increased heat show up on a thermogram. So part of the menopause method is mandatory thermograms if on 24 hours women go outside of the optimal zone of what's the right amount of estrogen. If there's more, we're going to do a mandatory thermogram. So it's not that I don't like thermograms. I think they're a wonderful tool used properly. I just will not accept thermography as the only way to screen for breast cancer. No way. Will not do it.
That would be a no.
And I'm very strong about what I recommend.
Got it. So, well, to segue in then, is it women do have a fear of mammograms? I have a great amount of respect for the mammograms I had, for sure. But the question comes in, is it okay to just go ahead and have an ultrasound and skip the mammogram altogether?
Good question. No.
Oh.
Not okay. As far as I know, standard breast cancer screening calls for a mammogram. Sometimes when you get a mammogram and there's a questionable thing seen on that mammogram, they'll follow up with an ultrasound. Ultrasound's less invasive. Of course, someone would prefer an ultrasound. It's less intense energy. However, last time I checked in, no radiologist would accept an ultrasound as an adequate screening tool to rule out breast cancer. It's a good tool to try and get further definition on a mammogram that's a little abnormal, but it's not acceptable as a breast cancer screening tool.
Thank you. I'm veering away from these questions just to see if you can answer these, because this kind of got me. On our chat, it says, "You're scaring me," when you were talking about the thermograms. And then above that, the Facebook user says, "Maybe we should just not use any hormones." Ooh.
Thank
Right?
you, Carolyn.
I just saw it. I got to ask it.
No, it's a good one. Well, what we train our doctors is a very simple statement. We say, there may be risks associated with taking hormones, although you'll have to tell me what those are, even though I've been in this field specializing in it for 30 years. I don't know what those risks are. You can overtreat a woman with estrogen, and she's most likely going to get increased breast density. That's a risk. Breast density is an increased risk as a breast health, and even for breast cancer. But I don't know what those risks really are. But I'll tell you, we guarantee that there's going to be problems if a woman does not have hormones. It's almost certain, near the 100% level, that a woman who does not have hormones is going to get bone loss, vaginal atrophy, increased risk for arteriosclerosis, quite an increased risk for cognitive decline to the point of dementia. Skin changes, mood changes, energy changes. Nothing works well. These hormones are our most powerful biochemicals in our body, and when we lose them, there are very significant consequences. Anyone who's been to Florida and walked and has a lot of exposure to elderly folks, or goes into a Florida assisted living facility or a assisted living facility anywhere, or a nursing home anywhere. I had a discussion with a doctor. We think that 80% of the women who are in assisted living facilities and in nursing homes are there because they lost their hormones. So they lost their muscles, so they go from canes to walkers to wheelchairs. They lose their bladder control, so they eventually wind up incontinent with adult diapers. They lose their minds. They lose their, take no hormones? No. No way. I'm a heavy advocate. Or talk to a man who's lost his erection, there's lost his muscles, and he can't walk. He's starting to use a cane. Or he has to go to a walker. He has to go to a wheelchair. There's a lot of men driving around those electric wheelchairs. Why are they doing that?
All the time.
Why are they doing that? Because most of them have lost these muscles in their lower extremities because of loss of androgens. Women lose their androgens. Women have as much testosterone, young women have as much testosterone as they have estradiol, the most potent estrogen. Gee, maybe there was a reason for it. Yeah, one of them is the safety of your muscles. We need these androgens and if you look at the lower extremities of elderly people, if you walk the Florida beaches, as I've done, because I lived there for a long time, one of the things that really stands out is you don't see a lot of elderly people walking the beaches. Isn't that remarkable? Because there's a lot of elderly folks in Florida. Much higher. And when you do see them, take a look at their thighs. Take a look at their calves. Very thin. They've lost the muscles. And the furthest extension of that is they have to go into wheelchairs. So don't take hormones. You never hear that come from me. I say all of us, including myself. Oh, what do you know? I put my testosterone on this morning. You betcha I did. And did a couple other ancillary things.
So did
treatment of a male. Talk to a man who's lost his erection in his 40s or his 50s or his 60s. Tell them you don't need your testosterone. So
not going to go over real well.
I'm extremely strong advocate of hormones, and I'd like to make a radical statement. Hormones don't cause cancer. Cancer has causes, oh yeah, but it ain't the hormones. Women who are treated with hormones are at less risk for breast cancer, heart attack, and stroke than women who do not take hormones. It's a really important thing to know. Chapter 3 in Happy Healthy Hormones, I really dive into the whole subject of risk, and I strongly advise you to read that. And if you want to know more, read Estrogen Matters by Avram Blooming and Carol Tavris. Women who are treated with hormones are at less risk for breast cancer, heart attack, and stroke than women who go untreated. Women who've had breast cancer, have had the breast cancer properly treated, that can involve surgery, chemo, radiation, some combination of that. They have an increased risk of recurrence of breast cancer than a woman who's never had breast cancer has of getting breast cancer. However, if that woman who's had breast cancer properly treated is treated with hormones, she's at less risk for recurrence than a woman who's had breast cancer and is not on hormones. Come on now. And someone in the chat asked about the BRCA mutation. Did you see that, Carolyn?
Do I need a mammogram if do I need mammograms if I tested negative for BRCA?
Yes, you do. BRCA does have an especial increased risk. It's not a guarantee, but it has an increased relative risk of developing breast cancer and ovarian cancer. That BRCA mutation, it's a genetic thing. But there are other causes of breast cancer. So absolutely you need a mammogram. Because
Got
the other causes are common enough that it's worth screening for. You know what? I didn't like any of the stuff that I started facing at midlife that had to do with medicine.
it.
I did not like that I was getting advised to get a colonoscopy.
Oh, they're
Who
fun.
wants to do that? The worst part of that was always the laxative.
Yeah, the prep.
But my father, they found malignant polyps in him. They removed them on colonoscopy, and he never had trouble with colon cancer. They found questionable polyps on me and my colonoscopy. So, do I do routine, appropriate follow up on colonoscopy? Yeah. And do I love going in there? No. But I appreciate what it does for me. Do I love going to the urologist? No. It's not the greatest time of my month for me when I go, or my year. But I'm so grateful for what urologists have done for me that I buck up and I go there with gratitude in my heart for for the
Absolutely.
good work that they've done for me.
Yes, agreed.
Who in the
Agreed.
heck wants to do all this medical stuff? Well, try not doing it,
Yeah.
but try taking impeccable care of your health. Get to be an expert at everything that matters. That's your main protection against not going to doctors. And I've had patients, I had a patient that she wasn't really a patient of mine. She was the mother of a friend of mine. She was a Christian Scientist. She was jumping ropes in her 70s. That was her daily exercise. She'd never been to a doctor in her life, nor did she plan to go. These exceptions do exist. God bless them. It's fantastic. It shows us what's possible for us. And she was fun and very cognitive in her late 70s and skipping rope. Bless her heart. Shout out to Carolina, it was her mother.
No.
So these folks do exist, and they're wonderful examples for us. But I wasn't one of those folks who got to escape the medical profession. And boy, when I needed them,
Right.
traditional medical doctors. I'm so grateful. I have so much gratitude to the good doctors that I've seen in my life. They've done good stuff. Sorry. Um,
Anyway,
yeah. Anyway,
um, I have a couple of questions here. Can bioidentical hormones shrink fibroids? I've been given 100 milligrams of progesterone, 1 milligram of testosterone, and biased, which I don't know that dosage. Will these hormones help the fibroids that I have?
um, it's an interesting question. There's many moving parts. Not all that I would need to know is revealed there. Um, Here's how fibroids are believed to develop. Estrogen stimulates the uterus. It stimulates the uterus to produce an endometrial lining, which is the soft, rich, fertile lining that a fertilized egg can land on and be nurtured. And that's what you menstruate once a month. It stimulates the uterine muscle. And it's balanced by progesterone. And that stimulation of the uterine muscle is balanced by your monthly output of progesterone. And women who don't have that balance, as I mentioned early in our Facebook Live today, they get overstimulation of the uterine muscle, by estrogen without the balance of the calming progesterone, and they get cramps
Mm.
and heavy bleeding. They get overstimulation of the uterus. And this is thought to be the origin of fibroids.
Ah.
Fibroids are benign tumor of the uterine muscle. They're benign. And so that's the good news about them. They're benign. They're not cancer. And how do they develop? It's thought almost certainly, although there's many causes of illness, and that's a whole big subject. And Carolyn, you wanted us to go into that bigger subject
And
on
we
one of our
will.
Facebook Lives. And we're going to do that because there's more to human beings than just the biology. But let's say that on a biological level, the probable cause of fibroids is overstimulation of the uterine muscle. Uterus is mostly muscle. By estrogen that's not balanced by progesterone. You get a fibroid. Now, that would seem like the remedy would be restore that progesterone and stop the growth of that fibroid by stopping the overstimulation of that fibroid by excessive estrogen, not balanced by progesterone.
Mhm.
Right on. That's exactly what we do. In fact, we go really rich on the progesterone when a woman does have a fibroid to see if we can arrest its growth. What's going to shrink it is menopause. There's no longer going to be these robust levels of estrogen. So what I like to emphasize to women with fibroids is that young women vary as to how much estrogen they really need to menstruate and be fertile and have regular periods. Some women need this amount. Other women need this amount. And other women are somewhere in between there. There's a 3 times amount difference between this woman who's fertile, healthy, regularly menstruating, and this woman who's fertile, healthy, and regularly menstruating. That's the range. Now, what's the optimal amount of estrogen to treat a woman, most women, 95% of the women with in menopause? Well, what do you know? It's right beneath there. It's right beneath the lowest amount. That, once the woman loses her estrogen, as she will when her ovaries stop producing it, that fibroid will stop growing and may even shrink. Or even if she gets treated in menopause with bioidentical hormones, 98% of the women are not going to be getting youthful levels of estrogen. They're going to be getting levels that are easy to balance with progesterone. So that should cause the arrest of growth of fibroids. Now, there's another question here as to whether or not this fibroid needs to stop growing.
It's a good question.
Proper treatment with hormones should arrest its growth because we're going to go robust on that progesterone. But does it need to shrink? Sometimes yes, sometimes no. Sometimes the fibroids are there and they're a hassle. And sometimes they're a big hassle. Sometimes they've grown so big that they're interfering with bladder function. They're painful once a month. And so they need to be arrested and shrink. But a lot of fibroids don't. They're benign. They're not cancer. And you get on the proper hormonal balance treatment with adequate progesterone, and you're going to most likely arrest their growth. So bottom line, if you have a fibroid, there's a distinction to be made about how much of a hassle is it, and can you achieve arresting of the growth and even fibroid shrinkage by ordinary non-invasive means? Yeah, you can a lot of the time. For one thing, your estrogen levels are declining anyway. And once your period stops, your estrogen levels have dropped to zilch. So you're no longer going to get overstimulation when you go into menopause. Menopause is the cure of problems with most fibroids, mainly because your estrogen levels have dropped so low. Can you replenish those estrogen levels and not disturb that fibroid? You betcha you can. And that's why I wanted to illustrate young, healthy women, they're somewhere in here. Menopausal women, 99% of them can be treated with levels that are not excessive, that don't even bring the period back. We don't want the period to come back in most, not all, but most women. We don't want it to come back. We don't want to do rich estrogen levels. And you can really jack up that progesterone to balance that estrogen and arrest that fibroid growth. So if this answer sounds complicated, it isn't complicated, it's complex. But the good news is fibroids are benign. Their growth can be arrested. Menopause is going to arrest their growth. Most fibroids are going to shrink in menopause, and you can go free with proper treatment of the menopause, regardless of whether or not you have a fibroid, because you're not going to need levels of estrogen that's going to overstimulate that fibroid. And you can do what we always do with progesterone. We always maximize its amount. Progesterone's so good for you. Why not take the maximum amount that your body will tell you about? That we describe in detail how to find that optimal amount or that maximal amount in Happy Healthy Hormones.
Yeah, 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 definitely. I reread chapter 3 for various reasons the other day twice. Um, so along those lines, we're talking about fibroids, but what about cholesterol? When we take compounded bioidentical hormones, does that affect our cholesterol?
One thing I didn't tell you is I definitely have a hard stop 3
Oh, you
minutes
say,
before.
I mean,
3 minutes
oh,
before the hour.
10 minutes before the hour?
Can it 3 minutes?
Oh, okay. I was going to say bye.
And the question was, what about cholesterol?
When we take CBHRT, does it affect our cholesterol? Raise it, lower it?
Only in a beneficial way.
Oh, okay.
Now, cholesterol is part of a family of biology, physiology. And at the core of cholesterol management is insulin. Oh, the same thing that manages glucose. And the cholesterol tends to rise midlife, not from hormones. It tends to rise because of excessive demand placed on the insulin glucose regulating mechanism. The final chapter in the book on weight gain discusses this in detail. So when you're getting an elevated cholesterol, you really want to pay attention to this element of helping your health. How do you deal with a glucose insulin regulating mechanism that's gotten too much stress and strain on it over the years, and it's not functioning in such a useful way as to keep the cholesterol low and keep the blood glucose low? How do you do that? Well, we discuss it in chapter, I think it's one of the last chapters in the book, and that's the main moving part. Now, what does hormones do to that glucose insulating, regulating mechanism? They help. For example, for thyroid hormone, thyroid can be a cause of elevated cholesterol, low thyroid. But for thyroid hormone to work at its very best, to really excel in what it does, it needs adequate progesterone in a woman. Progesterone, among the many things that it does, it sensitizes thyroid receptor sites to thyroid hormone. Estrogen relates to thyroid. So any woman who's on thyroid and we start her on estrogen, we want to keep an eye on that thyroid because of the delicate balance there, we may need to increase the thyroid dosages. So we do that in the menopause method. We're aware of that. We know that women who have thyroid issues, we need to watch them and just adjust the thyroid or start a woman on thyroid. So the moral of the story is ovarian hormones, progesterone, helps with lowering cholesterol because it helps the thyroid relationship to cholesterol. I mentioned the glucose insulin relationship to cholesterol. I also want to mention that thyroid helps regulate cholesterol. When I was in medical school back in the prehistoric times, before they had before the wheel was invented, fire had been invented, but the wheel hadn't been invented yet when I was in medical school.
They were working on it.
There wasn't none of the fancy thyroid blood tests that are very excellent that are available today. There was no TSH, there was no free T4, there was no way to measure T4 even, the thyroid hormone.
Right.
But my mentor in thyroid, a wonderful professor, shout out to Dr. Matavinovich, who's not on earth anymore. He said, you should be able to detect someone who's low in thyroid simply by your history and your physical exam. Thyroid's so powerful that when you lose it, you lose a lot of stuff that are revealed in history and physical. He said, but if you think you got to do a blood test, as if you needed it, just measure the serum cholesterol. Someone who's low in thyroid is going to have an elevated cholesterol. So all of these things interplay.
Right.
Replenishing of the ovarian hormones helps the thyroid, which can help with cholesterol, but there's the whole glucose insulin regulating mechanism that also plays into this. It ain't just thyroid. And progesterone can help the thyroid, thus help the lowering the cholesterol. Diet plays a role. There's a lot of moving parts. Exercise plays a role. And so really what you're looking at is midlife. And when you've put 10, 20, 30 years of strain on these very crucial, fundamental physiologic and biochemical mechanisms in our body, they all sort of interact. Moral of the story is do things to improve your health and get your hormones right. The largest section in our professional training program treating women and men with hormones is the thyroid section. Because midlife thyroid lowering from overstrain, that's what did it, is so common. It's almost epidemic.
So
to find a midlife person, male or female, with adequate thyroid, very rare.
I mean, stress, right? Plays a huge role in that. Yeah.
Yes, it overdrives the metabolism. And thyroid is one of the main regulators of metabolism. Well, you're putting excessive demands on the thyroid. Do that for a couple decades, and it just can't keep up anymore. Right. It doesn't necessarily produce thyroid disease. We're not talking about thyroid disease here. We're talking about a thyroid that's just not functioning at the rate of a 20-year-old thyroid.
Right.
I can take one more short question.
Ooh-wee. Yeah. Well, I guess I'm going to start with this question on our next, because I've got to get to this poor woman. Keep telling her I'm going to ask this question. Let me just say this. Progesterone spikes her blood pressure, and she feels that she needs to eat a few times per night. You brought up glucogen, due to being hypoglycemic. And I'm just wondering, like, do you feel that progesterone can spike someone's blood pressure?
Well, I would look at another cause of the spike. Because if she's hypoglycemic, that means her blood glucose levels drop too much. That's an unacceptable situation for the human brain. It's too sensitive. It always needs glucose. So the body has an exquisite mechanism to keep the blood glucose within a good normal range. Not get too high, not get too low. When blood glucose drops too low, the brain doesn't function. You start feeling faint, you start feeling a little wonky, and if it drops too low, you go into a coma. It's unlikely, I don't want to scare anybody. Under ordinary means, you can get hypoglycemic and you can get a little wonky, but you're not going to go into a coma with ordinary hypoglycemia. It takes a really severe pathology to do that, and most people don't have that. But hypoglycemia, well, we've got these exquisite and powerful mechanisms to prevent hypoglycemia. We got these two powerful hormones that are put out in the adrenal gland that if the blood glucose drops too low, these hormones shoot out and they raise the blood glucose. And we describe this in the book again. And those two hormones are adrenaline and cortisol. Anyone who's hypoglycemic probably is overtaxed their adrenal gland to the extent that they no longer have sufficient cortisol or adrenaline to rescue from a low hypoglycemia, from a blood glucose dropping too low. That's a big deal. No
And you
longer, you've tired out that adrenal gland that much. But hypoglycemia, like anything, you can recover from it by proper management. I doubt that it's the progesterone that has anything to do with hypoglycemia or the high blood pressure. Now, adrenaline has something to do with high blood pressure. If someone's got low blood pressure in an emergency room, what do we like to do? We like to give them intravenous, some form of adrenaline. It'll raise that blood pressure right away. Well, people are raising their blood pressure all the time by their fight or flight biology. They get scared, they shoot out some adrenaline, blood pressure raises. It's pretty much guaranteed the blood pressure is going to raise. So how does that relate to progesterone? I don't see that it does at all. Hypoglycemia does. You can get a squirt of adrenaline that's trying to protect you from the fall in blood glucose, and that can also raise your blood pressure. How about the hormones? I doubt that progesterone is the culprit there. However, some women have challenges with progesterone, and those need to be sorted out by an expert. Some women can't even take progesterone under all circumstances. Many women, if you have a properly managed progesterone, you know how to start really low and gradually increase it, or you know how to deal with a progesterone allergy, which does occur, or that's what needs to be done. So I'm going to say that I doubt that it's the progesterone, but it doesn't mean you don't have trouble with progesterone, and you don't need to have it you need to have it sorted out by someone who's expert at that, who's very well aware that women can have some super sensitivity to progesterone, and they just need to be managed different. And I've got to say goodbye for today.
So we will continue next week, and I thank you so much. Thank you for your patience, ladies. I don't know what went on there. Have a great week or weekend, or weekend, and the whole 8 more days or whatever it is. And I'll see everybody later. Thank you for being here, all.